So now we're doing the top 10 mechanical ventilation trials. The first trial to look at is the ARMA trial, ARDSNet, low tidal volume ventilation foundation, 60 cc's per kilogram, P plateau less than 30. This is a PF ratio less than 300, 10 US centers, 861. It was stopped at the interim analysis. In-hospital mortality was in the 6 cc's per kilogram, 31% versus 12 cc's per kilogram predicted body weight. P plateau less than 50 was 39.8. It was almost a 9% chance change in the mortality reduction, 10 to 12 ventilator free day difference. There was no difference in the barotrauma, meaning the lower tidal volume did not increase the pneumothorax risk. The low tidal volume strategy did have some transient respiratory acidosis, but it was expected and you shouldn't panic. This was the foundational trial of modern ARDS ventilation, 6 cc's per kilogram, predicted body weight, P plateau less than 30. You should know it cold because everything builds on this. The second study is the ALVEOLI trial. So we're looking now, patients all were with 6 cc's per kilogram predicted body weight with a P plateau less than 30, 549 patients, 23 US centers. And we're looking at higher PEEP versus lower PEEP on the FiO2/PEEP table that you could find on the NIH website. But basically, should we be adjusting the PEEP super high or just high? For instance, the lower PEEP strategy was the typical 18 PEEP, low tidal volume, 100%, and then you wean it down, PEEP, and then FiO2, as opposed to the higher PEEP where you're shooting it up all the way to 24, let's say, to start. The ventilator free days were identical in the PF ratio less than 200 subgroup. They did see that the higher PEEP actually benefited moderate to severe ARDS, but mild ARDS did not improve. Once the low tidal volume is in place, PEEP is the next lever. It's only meaningful in moderate to severe ARDS, so one size fits all PEEP tables are not the answer. PEEP strategy alone doesn't move mortality once the low tidal volume is in place, unless your ARDS is moderate to severe, PF ratio less than 200. The next very important trial is the PROSEVA trial, prone early and long. So PF ratio less than 150, greater than 16 hours. This is for severe ARDS. It was done in French and Spanish ICUs, 28-day mortality data, prone greater than 16 hours a day, started within a day and a half. 16% versus 33%. NNT was 6. 50% mortality reduction is probably the largest effect size in modern critical care. That's why it's asked very commonly on board exams. It's manageable. More unscheduled extubations, 13.3% versus 11%, but it was managed okay. Earlier proning trials failed. The Gattinoni 2001, Tacconi 2009, but they only proned for about 7 hours a day. Oxygen improved, but there was no mortality benefit. So you should prone early, prone long in severe ARDS, PF less than 150. This is not a rescue therapy. It's actually now standard of care. The next two trials to look at is the accuracies versus the ROSE trial. So these are neuromuscular blockade and ARDS. So the accuracies was cisatracurium, or otherwise known as Nimbex, 48 hours deep sedation, both arms, 31.6% versus 40.7%, 90-day mortality adjusted hazard ratio of 0.68. So there was apparent benefit of paralysis. The study was repeated in 2019 with cisatracurium. Again, Nimbex, 48 hours, plus deep versus light sedation. The ROSE trial was 90-day mortality, P equals 0.93. ROSE's control arm used contemporary light sedation. The accuracy's benefit likely reflected harm from the deep sedation in the controls, not benefit from the cisatracurium. The only thing that sort of refutes that is that the mortality was 40%, and it was 30% in the first trial. So basically, the current practice is that we reserve Nimbex or cisatracurium or vecuronium for severe dysynchrony, refractory hypoxemia, or severe acidosis. The next important trial is the AMATO trial. Amato trial, driving pressure and survival in ARDS. It's not the tidal volume, it's not the PEEP, it's the driving pressure. That's the PEEP plateau minus the PEEP. That's the end inspiratory pressure that you see on the ventilator minus the PEEP. Relative risk of 1.41 per 1 standard deviation increase in the change in pressure. So it persisted even on protective ventilation and plateau pressure. So relative risk is 1.36 among patients already on low tidal volume and safe plateau pressure. Our goal is to get you less than 15. The delta P normalizes tidal volume for lung size. So basically the driving pressure, not the tidal volume or PEEP in isolation, is the variable most tied to survival. Target driving pressure is less than 15. This is based on a meta-analysis by Amato, 9 randomized controlled trials with over 3,500 patients. The next must-know trial is the ABC trial, and this is the spontaneous breathing trial for liberation. This is done in 4 U.S. centers, 336 patients, a paired spontaneous awakening trial and breathing trial versus the usual care, plus the daily spontaneous breathing trial, 1 year mortality. And basically there was an improvement, 44% versus 55% in the 1 year mortality. Ventilator free days were less in the daily awakening, and the ICU free days were 9 versus 12.9. Hospital discharge days, 14.9 versus 19.2. But there was more self-extubation in the spontaneous awakening trial, 10 versus 4%, but no difference in the re-intubation rate. The self-extubations were not consequential, so it shouldn't let you stop from waking patients up. You should wake up and breathe together daily. A rare ICU intervention with a real 1 year mortality signal, again, 44% versus 55%. Trial is the Express and the LOVS trials. And basically for this one, we're looking at 2 trials published in the same issue of JAMA 2008, and they both asked whether higher PEEP plus recruitment maneuvers improved outcomes over lower PEEP ARDSNet strategy. So the Express trial looked at 767 patients, higher PEEP titrated to the plateau pressure of 28 to 30 versus minimal PEEP 5 to 9. The 28-day mortality was 35.4 versus 39%, not significant, but there were more ventilator-free days with the higher PEEP and significantly less rescue therapy. It was 18.7 versus 35%. The LOVS, we're looking at 983 patients, higher PEEP plus recruitment maneuvers versus lower PEEP. Mortality was neutral. Rescue therapy reduced 5% versus 9%. No excess barotrauma. Neither trial moved mortality, but both showed the same thing. Higher PEEP and recruitment reduced the need for rescue escalation and did not add harm. So this really set up what we'll discuss in the next trial, the ART trial. Okay, so you had the Express and LOVS trial, right? So now the ART trial is published with moderate to severe ARDS, 120 ICUs. So what you did is you did recruitment maneuvers with PEEP of 45. And then, so that's aggressive recruitment maneuvers. You could see the mortality 28-day was higher to 55% versus the ARDSNet low PEEP, 49%, increased risk of pneumothorax and barotrauma. So basically, Express LOVS showed that moderate PEEP is safe, and the R trial showed that extreme PEEP and sustained RM recruitment maneuvers were harmful. So aggressive recruitment maneuvers with very high PEEP caused harm. So you shouldn't chase the open lung approach with a sustained lung high pressure recruitment because that can kill. So then what about using physiology driven PEEP? We're looking at moderate to severe ARDS. We're looking at esophageal guided transpulmonary PEEP versus empiric high PEEP, FiO2. Just, should we know exactly? So the esophageal pressure estimates pleural pressure, and that could tell us what the transpulmonary pressure. So we should individualize PEEP for each patient's chest wall, relevant, especially in the obese patient. So should we use the PEEP based on what we find in the esophageal pleural pressure. Basically, the primary outcome, death and ventilator-free days, was not significant. Both strategies improved oxygenation. Esophageal guidance was feasible and safe. Esophageal manometry stays a research and selected case tool. A simple empiric high PEEP FiO2 did just as well. So physiology-driven PEEP titration is feasible, but not proven superior to a simple empiric high PEEP trial table. So here's a good way to remember this concept. So let's say your peak or your pressure of the esophageal pressure at end expiration is -5 and you're on a PEEP of 15, the lung is already held open. So that would be like at an expiration, in a normal person, you can have a esophageal pressure that is negative. So you don't need more PEEP. But if your esophageal pressure, let's say, is 18, somebody in really obese, and then they're on a PEEP of 12, the lung is collapsing on every breath, regardless of the PEEP setting. So the table will never help you there. So this is the concept here. And we're looking currently in this study. It was called the EPVent 2 trial. Finally, the EOLIA trial. We're looking at very severe ARDS, PF ratio less than 50 for 3 hours, or a PF ratio of less than 80 for 6 hours. France multi-center trial, 249 patients, 60-day mortality. Early VV ECMO was 35%, conventional 46%, but p-value was 0.09. There was 28% of the conventional crossed over to the rescue ECMO, so the high crossover diluted the apparent mortality difference. So there's likely a mortality benefit. And pooling with the Caesar and Riva registries, it showed that early ECMO benefited in carefully selected patients. The trial penalized ECMO by allowing rescue crossover, which itself may be life-saving. Most experts really used VV ECMO in carefully selected very severe refractory ARDS. So even though it's technically negative, it's practically a positive study. Use ECMO early in carefully selected very severe ARDS, and understand why the crossover complicated the literal p-value reading. So 4 more trials you should know. The FACT trial, conservative fluids, gave you 7 ventilator-free days. Remember, the liberal fluid, regular fluid, gave you 7 liters more after 7 days. The CREST daily sedation interruption, daily wake-ups alone reduced mechanical ventilation for at least 2 days in ICU length of stay. Less sedation is better. We looked at the ABC trial, pairing it with spontaneous breathing trial. Berlin definition of ARDS, of course, we have to understand the definition and the updated guidelines as well. PROSEVA predecessors, we went over Gattinoni and Tacconi in 2009. So finally, the 10 trials that I picked here as the top 10, the ARMA trial, 31 versus 39.8 mortality. ALVEOLI, PEEP alone doesn't move the mortality. Maybe PEEP PF less than 200, higher PEEPs could be used. PROSEVA trial, definitely a look at 50% mortality reduction. Accuracies versus rows, routine neuromuscular blockade is out. Amato shows you the driving pressure is key. ABC trial, 1 year mortality, definitely better if you do spontaneous awakening trial. Express and Lavs basically showed that the higher PEEP reduced the rescue needs, but not too much according to the ART trial. And the EPVent showed that esophageal guided PEEP was not superior to empiric the empiric table. And of course, the EOLIA, you have to remember the 28% crossover. It was technically negative, but practically positive. And that's it.